This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Cardiff University School of Medicine and the Noah's Ark Children's Hospital for Wales. It was published in Child's Nervous System in 2026, and it addresses a question we get in the clinic constantly, but rarely have a consensus answer for. Should children with a ventriculo-peritoneal shunt play rugby?
It's a classic dilemma, Ilara. We spend our lives perfecting the placement of these VP shunts, and then the parents, or more often the teenagers themselves, want to know if they can go out and get tackled on a Saturday afternoon. Historically, our advice has been quite conservative, often based on our own surgical gut feeling rather than hard data.
Exactly. The authors of this paper, Isabel Key, David Lois, and Paul Leach, rightly point out that as outcomes for hydrocephalus improve, we're being asked more and more about life beyond the immediate postoperative period. Participation in sport is huge for physical and social development, yet there's a notable paucity of evidence-based guidance.
So they decided to see what the collective gut feeling of the UK and Ireland's pediatric neurosurgical community actually looks like. Walk us through the methodology.
They conducted a nationwide survey of the British Pediatric Neurosurgery Group, or BPNG. They sent a structured electronic questionnaire to 70 members over 3 months in late 2025. They ended up with a 42.8% response rate, 30 neurosurgeons in total.
Now, some might say 30 respondents is a small sample, but in the world of pediatric neurosurgery, that represents a massive amount of clinical experience. As the paper says, it reflects hundreds of years of pediatric neurosurgical practice. What were they asking these surgeons?
It was a set of 5 dichotomous questions. First, they asked about direct experience with rugby-related shunt complications. Then they presented 3 scenarios based on age and level of play: a 7-year-old playing touch rugby, a 14-year-old playing contact rugby, and an 18-year-old playing at a professional or elite level. Finally, they asked about the use of protective headgear.
Let's get straight to the fear factor. How many of these surgeons have actually seen a shunt fail because of a rugby match?
This was the most striking part for me. Out of all those decades of experience across 30 surgeons, only 1 respondent, just 3%, reported witnessed experience of a shunt issue directly related to rugby.
And what happened in that one case?
It was described as a shunt disconnection. However, the authors are careful to note that because the timing was unclear and imaging might have been prompted by the sporting event itself, a definite causal relationship wasn't even established for that single case.
That's a powerful statistic to share with parents. If we're seeing almost no reported injuries in the UK and Ireland, it suggests the actual risk of mechanical failure during play is incredibly low. But what about the surgeon's recommendations? Did they actually say yes to playing?
For the 7-year-olds, it was unanimous. 100% of respondents would allow a 7-year-old with a VP shunt to play touch rugby.
That makes sense. It's non-contact at that age. But what happens when the game gets more physical?
When they moved to the 14-year-old playing contact rugby, the number dipped slightly, but it remained high. 80% of surgeons had yes. And for the 18-year-old at the elite or professional level, it was 77%.
That's interesting. Even at the elite level, more than 3/4 of pediatric neurosurgeons are supportive. That's a major shift from the don't ever play contact sports advice that used to be the default. Why do you think that 20 to 23% are still saying no?
The paper suggests that about 1/3 of pediatric neurosurgeons globally remain cautious and tend to restrict high-risk activities, despite the literature showing minimal risk. They reviewed other evidence as well, including a US-based survey which estimated that among 125,000 individuals with shunts, the incidence of sport-related complications is less than 1%. In fact, they couldn't find a single case of sports-related shunt injury documented in the medical legal literature in the US.
It seems the risk of litigation or mechanical disaster is more of a theoretical ghost than a clinical reality. Now, let's talk about the 5th question, the scrum cap. This is always a point of contention in the locker room.
Right. 77% of respondents advocated for wearing a scrum cap. Interestingly, the 23% who said no to the scrum cap were largely the same group who advised against playing rugby entirely. So if you're a surgeon who supports the return to play, you're likely to recommend protective headgear.
It's worth noting for our residents listening that a scrum cap is designed to prevent soft tissue injuries like cauliflower ear or lacerations. It isn't really a helmet for the brain. But in the context of a VP shunt, it might offer some protection for the valve site or the tubing from direct grazing or impact.
Exactly. The study really highlights that most of us are supporting a return to rugby, but we are recommending that protective headgear as a common sense measure.
Ilara, let's dive deeper into the clinical implications here. If I'm a resident in the clinic and I have a 14-year-old who just had a shunt revision and wants to play fly half for his school team, how does this paper change my conversation with the family?
I think it gives us a foundation for informed, individualized guidance, which is what the authors conclude is necessary. Instead of a flat no, you can tell the family that in a survey of the UK's top pediatric neurosurgeons, 80% would allow it. You can tell them that the documented rate of shunt complications from rugby is incredibly low, less than 1% based on broader literature, and that only one case of disconnection was reported by this entire group.
It changes the balance of the conversation. We're moving from don't do this because it's dangerous to here is the very low risk of disconnection balanced against the very high benefit of physical and social development.
Right, and the paper also mentions a study of 110 children with shunts where 73% participated in PE. Only 5% reported any sport-related injuries at all, and none of those were shunt-related. It really reinforces that these kids aren't as fragile as the old dogma suggested.
Did the paper mention anything about different types of shunts? For example, programmable valves versus fixed?
The questionnaire was focused on the general concept of the VP shunt rather than specific valve technology, though we know that in the broader neurosurgical context, we'd have to consider the risk of magnetic adjustment in programmable valves if they were using certain types of equipment. But that wasn't a specific focus of this rugby survey. The main mechanical concern mentioned was disconnection.
And that's a fair point. If a shunt is going to fail in rugby, it's likely a traction injury or a direct hit to the connector. But again, with only one reported case in this study, it seems the subcutaneous tunneling and the modern materials we use are doing their job.
The authors conclude by saying that these findings support the importance of providing that individualized guidance. We shouldn't be giving blanket bans.
It's a great piece of work because it bridges the gap between the known unknowns. We know we don't have a massive randomized control trial, and we likely never will for this, but having the consensus of 30 specialized surgeons is the next best thing for clinical practice.
It definitely makes me feel more confident in supporting my patients' athletic goals.
Any final thoughts on the study, Alara?
Just that it's a reminder that our role as neurosurgeons is evolving. We aren't just here to manage the hydrocephalus. We're here to help the child live a normal life. If that life includes rugby and the data says the risk is minimal, we should be the ones facilitating that safely, perhaps with that scrum cap we discussed.
Well said. This study by Key, Lois, and Leach is a valuable addition to our clinical toolkit. For those of you listening, we'll link the paper in the show notes. It's a quick read, but a vital one for your next clinic day.
Thanks for joining us on the Neurosurgery Hub podcast.
Stay sharp, and we'll see you in the next episode.